I was going to say good afternoon, but good evening, everyone. Thank you for joining us for BlackDoctor.org's Cancer Awareness Summit. I'm your host this evening, Shamika Rhymes. This summit is designed to empower you with the latest information on various cancers affecting our communities. And November is Pancreatic Cancer Awareness Month. So for this episode, we're talking about pancreatic cancer, and it's a disease that remains one of the most challenging and yet least understood cancers. So we're going to talk about, the signs and symptoms, risk factors, and advances in early detection and treatment options. And then we'll also take a look at the importance of research, the role of diet and lifestyle, and ways that you can advocate for yourself and your loved ones when it comes to cancer care. So let me introduce you to our panel tonight. Dr. Christian Apple, he is a physician and clinical researcher with over 100 peer-reviewed papers. He's on the faculty of University of California, San Francisco, and he's the founder and CEO of Sage Medic, a Silicon Valley-based cancer diagnostic company whose functional precision medicine platform utilizes the patient's own live tumor biopsy to identify the most effective treatment regimen. Hi, Dr. Apple.
Thank you for having me.
Thank you for joining. We've also got Neuroendocrine Tumor Research Foundation board member, Suzanne Ludlow. She's also a patient advocate, and she's here to share her husband's story, who he passed away from a neuroendocrine cancer of the pancreas. So we'll talk about that later. So let's introduce Suzanne. Hi, Suzanne.
Hello, I'm so glad to be here.
Thank you for joining us. So like I was mentioning, this is an important topic. So Dr. Apple, can we start by explaining exactly what pancreatic cancer is and how it develops in the body?
Yeah, sure. So the pancreatic cancer is actually a cancer of the pancreas. So the pancreas is an organ that produces digestion enzymes. So it produces lipases, amylases, and proteases. These are all enzymes that break down what you have eaten. That's released into the small bowel together with the bile that comes from the liver. And they make sure that the food is processed in a way that they can be absorbed by the body. And these cells that actually produce this juice, so to speak, those exocrine come from the exocrine ducts. And exo means outside. So exocrine is something that's secreted into the lumen of the gastrointestinal tract. And in contrast to endocrine, which is actually are enzymes that are released into the blood. So endocrine tumors that often can be benign, but can also be malignant. And then these are endocrine cancers that can be very difficult to treat with. They produce hormones that are released into the blood. So the pancreatic cancer in 90% of cases is basically exocrine duct cells, often called adenocarcinoma, and they often grow aggressively and spreads early to nearby organs.
Okay, thank you for that explanation. And I forgot to tell everybody to drop your questions in the chat. If you have any, we will try to get to those towards the end of this episode. So make sure you drop those questions in the chat and share this with your network. What are some of the early warning signs or symptoms of pancreatic cancer, and why is it often diagnosed at a later stage, Dr. Apple?
Right, and so that actually alludes to the challenge that usually there aren't any early warning signs. So the typical signs are jaundice, abdominal pain, sometimes back pain. You can actually have loss of appetite and unexplained weight loss. You can also have night sweat and other non-specific symptoms. And so they're usually only diagnosed very late. Jaundice, for example, is a symptoms usually on the pancreatic head. So the pancreas has a portion that's closer to the small intestine, where also the duct comes in from the liver. And if there is a cancer so that the liver can't deliver the bile into the gut, then it's kind of stacks up and then comes into the blood and then causes the jaundice. So jaundice is often a late symptom of the pancreatic cancer obstructing the outlet of the bile into the lumen of the small bowel so that it goes into the blood and therefore shows up in the skin. And if you have a cancer in the tail of the pancreas, that usually doesn't cause jaundice, but it also, of course, can be cancer.
Thank you. For this part here, I wanted to ask Suzanne if you could share your story about your husband and any symptoms that he may have experienced. Was it early or late, or can you tell us a little bit about that?
Sure. My husband, Vincent Taylor, passed away from neuroendocrine pancreatic cancer in 2017. And as Dr. Apple mentioned, it's not the typical kind of pancreatic cancer. It is the one that Aretha Franklin and Steve Jobs and Maria Menounos have, but it's different, and so it's a little bit specific. My husband was thin, and he's African American. He was thin, and he could feel something. Essentially, he felt tumors in his liver. And it took a little bit of investigation and testing. They did see the tumors in the liver. They had a liver resection. They cut out part of his liver and tested the tumors and found them to be neuroendocrine. So he felt uncomfortable in his abdomen. That was about it. And I think that's somewhat typical. We don't know how long these tumors were growing. And at the time, we didn't know where they came from. Mm-hmm. They had metastasized to the liver. The pancreatic neuroendocrine cancer is generally less aggressive than regular pancreatic cancer. But among neuroendocrine cancer patients, African Americans tend to have a more aggressive version, have a little less health, less good outcome of the cancer. And so it is one of those things that's troubling. As we go through this, and I'm sure Dr. Apple has many examples, people just don't feel good, right? The descriptions are really generic. Doctors will try to rule out irritable bowel syndrome or menopause or a variety of things that are uncomfortable, and not necessarily look for cancer. I think one of the things that I wanted to kind of give an example about, though, was the need to be an advocate for yourself as you're going through this. And for example, like a real eye-opener was that when my husband and I went to his first oncologist appointment, and then we were reading the medical summary of that appointment, it said he was a heavy drinker. And he hardly would drink, but he's Black, he's got tumors in the liver, must be a heavy drinker.
Wow.
And my husband was furious. And it took months for us to clarify the record. Obviously, when you go through and they answer the questions, how much do you take drugs or drink or sleep or smoke or whatever, he was honest about that. Nevertheless, assumptions sometimes get made. You have to be an advocate for yourself. You have to check the record so that you don't have, wrong. I mean, once it's in a record, it's hard to get out. So, that was kind of our entry level into how important it is to really be an advocate for yourself and have other eyes on it. So that was kind of our starting point in the journey of about 6 years dealing with his cancer.
Thank you for sharing that. I am just floored right now by that. Yeah, wow. Dr. Apfel, can you walk us through that process of diagnosing pancreatic cancer, like what tests and scans are typically used?
Yeah, happy to do so. I first wanted to comment on Suzanne's experience. You're not alone. It is not uncommon that with the workload that many physicians have, documentation is done in a hasty manner, And so it's very unfortunate, and especially where it looks like there is it feels like a cultural bias or racial bias that may have fed into this. And I think it's one argument is you need to be your own advocate. That's really, really important. So if you actually are facing a serious diagnosis, you need to actually take things into your own hands, and you cannot rely on the healthcare system to have a superior outcome. The healthcare system is designed to give you a standard of care per requirements, and you cannot expect a superior outcome just within standard of care. And so, first of all, you need to check, you need to educate yourself, you need to buddy up with, I would like to say, patient advocacy organizations. In the pancreatic cancer space, there is the Pancreatic Cancer Action Network, PanCAN. There is the Lustgarten Foundation, which is a private foundation from a large donor. There is a National Pancreas Foundation, NPF. So try to educate yourself. What's the stage? Where are you? And you actually need to, and that's a quote, speak up for your health. So it's a quote because Dr. Arkell Giorgio has a YouTube channel on that topic where she interviews patients in their life journey, not only cancer and all various other areas. It's really important that you speak up for yourself. And it shows in this case, it's another indication why, especially if you are an African American, that you need to be twice as proactive to speak up for yourself. And you also, what I would highly recommend is surround yourself with a support team. The diagnosis is psychologically extremely difficult. It's threatening. It's a roller coaster, and it is really important that you surround yourself with others who help you on the journey, who participate in the conversation, so that you can make a good informed decision. I think that's a really important. So being an advocate is really, you're doing a really, really important job, and I want to emphasize that.
Thank you.
So now I need to get back to your question.
That's okay. No, that was great. That was super important to highlight. So thank you for that.
There is another part, speaking up for yourself. There is research from Dr. Snyderman from MSK, Memorial Sloan Kettering Cancer Center, has recently published a paper on the importance of second opinions. I'm not sure whether it applies to all states, but in California, a patient has even the right to get a second opinion on the proposed treatment plan, and that has to be covered by insurance. And in, I think, 30 or 40% of cases, the second opinion leads to a change in treatment regimen that is likely to be associated with a superior outcome. So you really need to be proactive. You really need to think about, who else do I want to get involved? I want to get a different perspective, really to make an informed decision. And it's so difficult because most of you who get diagnosed are not medical professionals, and it's a very complicated matter.
Yeah.
So second opinions as well. Speak up for your health. Try to have a support team. Engage with patient advocacy groups. They're doing a really important job, and then get second opinions.
So okay. He's stolen all my thunder, which is wonderful. Obviously we need to go through some of the medical issues about pancreatic cancer, but one of the things that was interesting, my husband's brother is a physician, mm-hmm. and he insisted to my husband that I go to every other doctor's appointment. You need to have the other set of ears there, whatever. So he had privacy half the time, and the other half the time I was there. So you need that. I'm happy to talk a little bit more later, but let's hear a little bit about the the diagnostic process. It's just amazing work that the doctors do for this. So Dr. Apfel.
Well, thank you. Yeah, so the diagnosis is often done based on a CAT scan, additional imaging. I'm not sure how it was in your case. CAT scan is usually less expensive than an MRI. When it comes to the pancreatic cancer, you want an MRI because the MRI gives you, especially when it's around the head, it gives you a better resolution of the soft tissue and how resectable it actually might be. And because the simple slogan is, if you're at stage 1 or stage 2 pancreatic cancer, a chance to cut is a chance to cure. If you can actually remove it before it actually has spread to other parts of the body, you actually have a reasonable cure rate. And so that's one of the reasons why screening is important. But pancreatic cancer is too rare so that there is not a routine screening method. And so it's usually only diagnosed in stage 3 and stage 4. Now, in regards to screening, there have now been developed so-called liquid biopsies, which is a blood draw, so-called pan-cancer tests. So tests that actually, blood tests that cover a wide range of tumors. And Grail, which is a large company, a spin-out out of Illumina, has actually developed the Gallery test. The results are published 2021 in Annals of Oncology. Everybody can read it up. Many cancers that are currently not screened for can be detected with 80% of sensitivity. It's submitted to the FDA so that they can make a claim for screening. But the FDA has been sitting on it for years, because if the FDA would say, yes, this is what everybody should get at the age of, let's say, 60 or whatever, then insurance companies may have to pay for it. And that would then increase the insurance costs. And so that would actually, there are strong economic forces and political forces that actually prevent this innovation to get accessible to the wider audience who would benefit from such a screening test. It's currently available as an out-of-pocket expense. It's $990, I think, last time I checked. And it's not perfect. It doesn't have 100% sensitivity, but I recall that pancreatic cancer is picked up with 50% sensitivity in stage 1 and stage 2, and over 80 or 90% in stage 3 and stage 4. So that is something if one can afford it, one can consider. I wouldn't do it at the age of 20 or 30, and it certainly doesn't make sense to do it every year, as of course the company probably would like to. Yeah. But perhaps every 5 years, or at least every 5 years, or every 10 years, having this starting at the age of 60, where actually the cancer risk is really rising. And keep in mind that many cancers have been around for 5 to 10 or 15 years before they become symptomatic. So if with a Grail test, we could, and there is an example on a pancreatic cancer patient that's actually, I can find the source for you. And he has actually testified before the Congress to get this covered by insurance. So there is, and he got the test. It was positive. He got on the next day an MRI, also out of pocket pay. He could afford it. And he got the surgery and adjuvant immunotherapy, even out of the country. And he's completely free of residual disease. But that's for the wealthy, right? At this point, because it's not covered by insurance. So that's two parts. One is blood test. The Grail test, the Gallery test from Grail, is one possibility. Whole body MRI is another one. That's in the similar price range. Again, I don't think it makes sense to do this every year, but every 5 or every 10 years, starting at the age of 60, could be an investment that I at least decided to make for myself. I want to pick up things early, because if you are picking it up at stage 1 or 2, you have an 80%, 60 or 80% chance of 5-year survival. If it's stage 3 or 4, your survival chance at 4 is actually below 20%, 5-year survival. So that's really, really important early screening, and there is no way to know it ahead of time.
Thank you. You mentioned, Dr. Apple, about the different screenings and things like that. So if they're for the ones that have to rely on their insurance, what can they do since they can't afford those expensive tests? Is there anything they can do? Or if they're having to pay out of pocket and it needs to be kind of a
So
reasonable
the only
cost?
thing you can actually do in a way are lifestyle changes.
Okay.
So African Americans are unfortunately have a 30 to 60% higher risk of developing pancreatic cancer in general. It's not completely understood why, but so you can't change that. But what is very clear is that there are certain risk factors. That is, obesity is a risk factor, being overweight. Smoking is a significant risk factor for pancreatic cancer. It's often under-recognized. Managing diabetes is important. And if we go with Dr. Peter Attia's book called Outlive, regular exercise. Regular exercise is actually the longevity drug per se that you can actually have. And you don't have to become a Olympic athlete to get your health benefit. But it's very interesting that regular exercise works on 3 different areas for your longevity. It reduces your cardiovascular risk, which is one of the main horsemen of our Western diseases. Cardiovascular risk is reduced in terms of stroke, heart attacks. Second, it reduces the risk of cancers across the board pretty effectively, more than I thought. Third, which I didn't know, it seems also to reduce the risk of dementia, so Alzheimer's. So regular exercise, and you could start this off very slowly with having a walk every day, and then perhaps having some vigorous exercise once or twice a week, and really developing that and keeping your weight controlled. That's really one important thing to reduce the risk. And there are also two interesting channels on nutrition, because in principle, what's also quite well established is that with a plant-based diet, you actually also lower the risk for cancer in general. It's been well established for colon cancer, but it's the correlation for cancers in general also very strong. So there is the channel Nutrition Made Simple by Dr. Cavallo, or nutritionfacts.org by Dr. Michael Greger. Those are resources you can access today and cut your risk of developing pancreatic cancer basically in half. And not only pancreatic cancer, there comes a number of other health benefits along with it.
Mm-hmm.
One of the things I guess I'd like to speak up on is that, you ask, is there screening or whatever? Part of it is to know what your body feels like.
Mm-hmm.
And if it's not feeling right, keep pushing for an answer. That's what my husband did. He knew something was wrong. It took some work to get the attention that he deserved. But that's for the folks that I work with within the neuroendocrine cancer community. Story after story after story is they just felt something wasn't right, and they went to their doctor and pushed to have it investigated. So yes, you need to do all the healthful things. Sometimes as healthful as you can be isn't enough, and you're still going to get the cancer. But you have to be able to not just be intimidated or think it'll go away. You do need to check things out. And so part of it is just being vigilant about that and persistent about having respect for your body and hearing your body when it says something's not right.
Mm-hmm. I
And
think that's important because a lot of times people are afraid to go to the doctor, especially in the Black community. They're just like,
Right.
"Oh, it'll be fine. I'm not going to even worry about it. It'll go away," and it doesn't.
Right.
right.
I'm sorry, Dr. Apfel.
Yeah, well, I just wanted to agree. Um, you had another question. Did that answer your question on early
Yes.
diagnosis screening? What can you do if you can't afford the screening? I think that's the best answer I can give at this
Oh no,
point.
that was great. That was great. What are the current standard treatment options available for pancreatic cancer, and how do they vary by stage? It sounds like, well, you mentioned earlier, if you can cut it out with stage 1, stage 2, but what about when it gets to stage 3, stage 4? How do you treat it?
Yeah, let's go through this systematically. So, if you are lucky, which is a doubtful word for in this case, if you're lucky to be diagnosed with stage 1 or stage 2, um, you can. There is a way to, based on where it is, to remove it. So if it's in the pancreatic head, which I mentioned before, there could be a so-called Whipple procedure called pancreatic duodenectomy. So the pancreas and the duodenum is cut out. Duodenum is a part of the small bowel. And it's actually the most common surgery for tumors in the pancreatic head, and involves removing a part of the pancreas, the duodenum, so the small bowel, as well as the gallbladder and the bile duct. And so that's kind of a common procedure. The other one is if it's in the tail, then you can have a distal pancreatectomy. So it just takes off, and it's much easier procedure. It often also takes out the spleen as well. And then if the entire pancreas is involved, you actually do a total pancreatectomy. So which is really a larger procedure, but it usually it's usually only done when the tumor hasn't metastasized. So that means you actually want to know, when you get the diagnosis, you want to know, are there any other parts? And one way to do it is the MRI, but there is also the PET-CT, which is a substance is given to make glucose lit up, and tumors like to eat glucose, and so it can show up in the liver, could show up in the bone, it could show up in other parts of your body, and then you would know there is something else going on there. And if you already have metastases, we, in general, such an invasive procedure of taking out the whole pancreas is usually not benefiting you and would do more harm than good. So you want to know what's your staging. And so that's one of the reasons why exploratory laparoscopies are really important. And that would also be an opportunity to send a specimen to Sage Medic, so my company, for example. So I
Yes.
probably should
Can you give the
also.
website for that real quick?
Right. Thank you. And I should briefly tell you a little bit about Sage, if I may.
Yes.
So I've been a physician and researcher for over 20 years, and at some point, my dad was diagnosed with lung cancer, and it was very clear that he refused therapy, and he said to me, "Unless you can promise me this is going to work, I won't have it." And the background was that my mother actually passed away from ovarian cancer, and the treatment in her last months of life didn't work. And I've worked in a different field before that, and it was, to me, a wake-up call. I'm a physician, and I had no idea that what we call precision medicine is by no means as precise as we would like it to be. The challenge is that only 1 out of 4 patients have actionable mutations, so genetic alterations where we have an idea which targeted therapy might work. And for most others, it's chemotherapy where we actually don't know how well it works. Often it's only 30% of patients are responding to the therapy, and while most patients have actually severe side effects. And so I said, how can this be that we are practicing medicine and giving a drug and not knowing whether it's going to work? And so I said, there must be a better way. And the best way to know whether a therapy can work is actually if you try it out. But you don't want to try it out on the patient. You want to try it out on the tumor. And so we developed a technique where we can take a fresh biopsy, and it needs to be viable tissue of your own tissue. And then we can create hundreds of microtumors in vitro. They are so small that you can't see it with your naked eye. And we can drug them until they're completely drunk. And we can then see within 1 week which therapy is potentially effective and which therapies can't work. Because if we do a very high drug dose or in vitro and the tumor is still viable and is not affected by that, if it can't work in vitro, it will also not work in vivo. And we shouldn't expose the patients to all the harm and the pain. And so that's what Sage Medic has developed. And so if you are going for a biopsy, if you're going for exploratory laparoscopy, what I'm just mentioned, then that's actually the ideal opportunity to get tissue sent to Sage, and so that we can examine it. So, and that's something very new. We launched this year. It was years of development. We started this on our own dime. We used our retirement savings to get this off the ground and to develop the technology. That's non-trivial. But now there is something available that can provide you additional information. So one part is the surgery for the early stage, but then you also will need adjuvant therapy. And these are gemcitabine is one option. This can be FOLFIRINOX, which is a more aggressive therapy. It's usually a combination of 5-FU, leucovorin, irinotecan, oxaliplatin. That probably doesn't mean anything to you. But actually, if we look at it in the lab, in the individual drugs and the combinations, very often there's only 1 or 2 of those drugs that are effective, whereas the others are doing nothing. And so that's also information that's important to know. And then if you have a BRCA1 or 2 mutation, right, which is often the mutation for breast cancers or ovarian cancer, men in particular that have BRCA1 and 2 mutations can actually develop pancreatic cancer. And there have been some projects thinking about it, whether BRCA1 and 2 men should actually be screened for prostate and pancreatic cancer. And so that for those, we usually PARP inhibitors, and we can test all those things in the lab. So that was stage 1 and 2. And the drugs, they are also usually given when you can no longer operate on. And you can also think, and that's the other part why an exploratory laparoscopy would be important, because you will see more than you can see with the MRI. You do the exploratory lab, you, for example, get sent one tissue to Sage. And then the question is, can you do neoadjuvant chemotherapy, meaning therapy before the surgery, so that you can shrink the tumor to make it operable? Because if it's localized, and sometimes it's really hard because it has infiltrated in other areas, but if you can actually shrink the tumor with an effective therapy, if the tumor responds to the chemotherapy, you might convert it from inoperable to operable. And that could actually get you to the cure. So, but that's also where it would be important to have some sense of whether the chemotherapy could actually work.
Thank you. Suzanne, I was just curious as to what treatment options your husband was a part of. Like, was it to the point, I know you mentioned surgery earlier, but was he able to take the drugs, or did he have to do chemo, radiation? What did that look like?
Well, neuroendocrine cancers function a little bit differently, but there are a number of kind of treatments to help slow the progression of the cancer. He had bowel blockages. And so at one point there was surgery. They thought they saw where the primary tumor was on a CAT scan. He had a couple MRIs, but he was allergic to the contrast material of MRIs. So we ended up with CAT scans mostly. The surgery was unsuccessful, was not able to remove the tumor. And so there's a variety of different kinds of drugs that he was given, and various liver treatments to reduce the number of tumors in his liver, which was a problem over time. I think, that was also between 2011 and 2017, and there's been remarkable progress of new treatments, new screening methods that are out there. The Neuroendocrine Tumor Research Foundation that I'm on the board of gives grants for research for the kinds of, first, what are the cells, right? All of the really basic research, but then the kind of treatment options that are really important. And they do have a whole section on pancreatic neck cancer research, which is not commonly done. So it's important work, and I'm glad I'm associated with the foundation. For my husband, he had to think a little bit about if he wanted to do clinical trials. And so just, one of the things that's important is that you have to, first, he wanted to help other people. So the idea of a clinical trial in general, he appreciated, and he participated in several different kinds. But he also kept wanting to work. He wanted to have his life. He didn't want to have, some of those trials meant going to the hospital every day for something or whatever, and that was too invasive of living. Because part of this is, you're more than a cancer patient. You have a family, you have a life, you have a work, you want to cook, whatever it is, you have to figure out how to mentally, be alive and live your life while you have a disease. So you went through a lot of those things. And some of the new information on the kinds of screening tests that there are, different kinds of scans that are out there. There's some immunotherapy options and things that are really being looked at. It's not in hand yet, but it's real progress. And the difference from when we were trying to figure it out before and what there is now is tremendous. I have to say, though, our health system's tough. And so fortunately, my husband had dual health insurance. I had my health insurance. He had his health insurance. But the medicines that he was taking could be $17,000 a month. I mean, that's really, if you don't have that kind of insurance that will cover this, it's a different system. And, those are just those. We want to catch this stuff early. I think similar to what Dr. Affel said, if he had caught the tumors before they had metastasized, you can cut them out. And that's highly successful. It's just finding them first is really, really hard. I think I also want to go back to one piece of information. I think we talked earlier about the impact of race disparities or other kind of disparities. There's geographic access disparities. People don't necessarily live where the right doctors are. We didn't get to a person experienced in neuroendocrine cancer early enough in my husband's care. That was a problem. You do have to find the right doctors that have the knowledge that you need. But there's huge resources in the Neuroendocrine Tumor Research Foundation webpage. So it's netrf.org. And they have a patient guide, they have all kinds of videos and podcasts. And one that I want to bring attention to everybody on this program is podcast 27, which is NETs and Race. And it's really not specific to neuroendocrine cancer, but it talks a lot about the different ways that where you live, what your heredity is, how you're treated, what your environment is, how these things all interrelate as you're dealing with your cancer diagnosis. really, really good program. And, you can reach out and get this information, make connections with other patients, hear how they're going through this. My husband, he didn't want to do that, right? He was private. He wasn't going to get into a group setting, but many people find them very helpful.
Mhm.
And so there's a lot of things for whichever kind of cancer or issue or specific area you're in. You can find some real connections and good advice about just how to deal with day-to-day things. When you're dealing with something with the pancreas, it messes up your, your whole digestive stuff, the different things that go on. You can talk about that with somebody else and find some hints that might make things a little bit better, or just that other set of ears that you need to bounce your concerns off of. So the resources, PanCan, the ones for Dr. Apfel, NetRF, all are really helpful. And you're not alone out there. I just want people to know you're not alone. People have gone through this. Everybody wants to help people make this not as horrible as it might seem at first, because we're all getting through life. So let's do it together.
Thank you. I know we're running out of time, but I do want to make sure I get this question in, which is because, like you said, patients should have their support system, someone go with them to the doctor. What are some questions that the patients should be asking doctors to make sure that they're getting all the available treatment options, that they're getting all their questions answered? Is there something like, maybe 3 questions they should make sure they find out when they go to the doctor? And either one of you can answer that, or both of you.
Well, I think one of them is, how much experience does a doctor have with that particular type of cancer, is a really important one. And what are the, you don't just work with one doctor. You should be having a team. There should be a nutritionist, and there should be somebody to help with mental health and how you get through all that. So, asking about what does that team look like, I think is really important. I'm sure there's more specific ones that Dr. Apfel has in mind, but I think that from a patient perspective, going in and not knowing anything about a complex cancer, the first thing is to hear how much knowledge does the team have and how much attention can they give to you as an individual for dealing with it. It's not standard of care, right? It's what is for you. Is this the right place for you? And are you getting the explanation you need or whatever? It's really important just to put it out there and find out if it sounds like it's a good fit.
Okay, thank you.
And in particular, if it's a rare cancer and you can frame it in a way saying, so apparently the tumor that I have is quite unique, rather than perhaps questioning, well, how much experience do you have? You could actually say, do you think there are specialized centers that have other resources and have other thoughts on this? What if you were diagnosed? What would be your advice? Would you seek out another second opinion that is specialized in this field?
So, that's right. And if I can interrupt, that we ended up getting those other opinions, and then they were working with our local oncologist. So you don't have to get rid of the one person. It can be a joint effort.
Mm-hmm.
Excellent. Yes, I think that's important. I think it's also important to get clarity on what type of cancer is it? What histology type is it? What stage is it? What are the what are the prognosis? What are the standard treatments? What are the pros and cons of each of those treatments? And so I'm a very quantitative person. I want numbers. I want to know, how likely is this going to shrink the tumor? Give me the numbers. How likely is it that I have some side effects? What are the side effects? What about polyneuropathies? I personally wouldn't mind losing my hair, but if I would actually lose my sensation in my fingers, or or I would have tingling in my legs or pain in my legs, and I can't sleep anymore, or I can't walk straight anymore, or drive a car. That's something different for me. So polyneuropathies is part. So there are understanding what are the side effects, what are the different treatment options, and what are the pros and cons, and get the granularities on the pros and cons. And then there are all major organizations, so the NCCN, the National Comprehensive Cancer Network, they have patient brochures. They're usually well done. They give you a very good overview. You should know those in and out. And then once you have done that, then you need to educate yourself to be able to ask the right question, because the challenge is you don't have the knowledge to ask the right questions. And so you need to educate yourself, and you can't do this in the first meeting. And in general, what most oncologists will tell you is what they tell you in the first meeting, you'll likely not remember. And what's also not unusual is that the oncologist may say things as they are accurately, but you may, based on your own view where you are coming from, hear something very different. And so that is one of the reasons why it's important to have another family member part of this, and then check in. And so not say, oh, he said this and this and this. If you are uncertain, just verify and check back in and say, read back to the oncologist and say, oh, did I understand it correctly? I heard this. Does that mean? So always exploring, because it's so complicated.
Yeah, thank you. Suzanne, did you have something you wanted to add?
I think that's all true, and it changes over time, right? Your progression through this process, sometimes what you heard the first time, maybe it's a little different the next time because of your situation. Write down the questions, but also don't be afraid to say something. So many people are intimidated in the doctor's office. And, I would go with my husband, and the doctor would ask, well, how are you feeling? And I'm like, I'm okay. And then I'm like, tell about the pain last night. You don't want to hold up the doctor.
Yeah.
No, you have to actually, it's a two-way street. You have to share the information.
I also wanted to comment on situations when it gets tough. If the treatment stopped working, I do think the Sage Oncotest may be an option. But you may also at some point reach a point where, let's say, the assay shows none of those treatments work. What do you do then? It is not unusual that patients get treated too aggressively, and that it does more harm than good, that it actually shortens life. There are some studies that actually have shown that early engagement of palliative care can actually not only reduce utilization costs, but actually increase quality of life, and in some cases also length, survival. And it has to do with, if you get treated with ineffective treatment that only makes you worse, it not only decreases your quality of life, it may also shorten your life. And so don't assume by accepting more and more aggressive treatment that at least you live a little bit longer. It may not be, right? So it's not necessarily a trade-off between quality of life and extension. There may be, if the drug is not the right drug for you, that it would not be good for you. So engagement of palliative care in an early stage, in conversations, palliative care physician can be beneficial. And then there is another part that I think, Suzanne, I would like to see what you think as a patient advocate. I think it's really important to have clarity on the conversation, what the patient wants, if the patient can no longer make decisions for him or herself. And the relatives need to get together, ideally with the patient, and find an agreement and understanding of what does the patient wish. Because what's really hard, if the patient can no longer make a decision, you have different family members. Everybody wants the right thing for their loved ones, but the perspectives may diverge because they may think that the patient may want something different. And big conflicts can arise within the family. Just caring for this in the last days or weeks of this patient, and then creating downstream aggravation if there is no clarity around it. So there is an interesting book from Atul Gawande called Being Mortal that addresses this question. I see you are smiling. You are apparently familiar with this book. And so getting clarity of what's important to the patient and having open conversation is so important for the support staff to be able to support you as a patient, and also making sure that the people who really did the best they could are kind of in agreement.
Yeah, I mean, we we eventually went into have hospice care at home. There was a lot of good conversation about making the connections early, because then you can say what you want. If you wait till the last moment, then nobody knows what you want, and it can just be uncomfortable. And instead, we had beauty in our lives, and that's, you want to, if you're sick, you want to go out in a beautiful way. You want to be there with your loved ones. You want to be as comfortable as you can, and there's it's very moving. I have to say, it's very moving. I do know a lot of times doctors don't want to give up, and they push treatments and things. And one of the things that my husband said, which I thought was really interesting, when he was considering some more aggressive clinical trials, is, he was asking, well, do I have a choice? And yes, you have a choice. And then he's like, well, I'm going to choose the one where I'm happier. I mean, seriously, that's what you're trying to do. You're trying to be happy and live in a loved situation. And so, do communicate your preferences, recognize that your preferences can change over time. And so you have to have the conversation again over time. But what you want is that loving, healthful relationship, even when things are really tough. And that's, I think, I'm hoping that all this information here helps everyone get to that point in treating their cancer.
I want to thank you both for, sharing all of this knowledge, and Suzanne, sharing your story with us. This has been great. I feel like we need a part 2 at some point because it was just so good. Dr. Apfel, do you want to mention your website before we go?
Sure. sagemedic.com. So one word, not medical, just sagemedic.com is our website. I can also, if you have a loved one who is affected, happy to have a free half-an-hour conversation with you to see whether the Sage Oncotest could be helpful for you and may be beneficial. I'm always willing to help.
Okay, thank you so much. I hate we've got to cut this because we have another show coming up right in a few minutes. So everyone check out blackdoctor.org for more articles on cancer, but stick around. Like I said, in a few minutes, we have the episode on cervical cancer. And, we're here the rest of the evening with the Cancer Awareness Summit here on blackdoctor.org. Thank you both again for joining us. And I will see you guys in the next panel in just a few minutes.
Thanks very much for this.
Thank you. Bye-bye.